We didn't tell you at lunch, but we're all going for a 30-minute walk outside. So, Dr. Gore.
Thank you very much. It's great to see so many familiar faces. I'm actually standing up here on behalf of a research program that's led by Ruth Etzioni, but she unfortunately couldn't be here today. And I want to talk about screening for prostate cancer, which is an issue that incites a lot of passion. But what I want to represent is what we and Ruth's group have done to try to do more of a critical evaluation of some of the screening concerns. So in 2012, there was this landmark statement from the U.S. Preventive Services Task Force that recommends against routine screening with PSA, with the prostate-specific antigen test. And their rationale kind of came down to a number of bullet points. So number one, there was a big screening trial in the U.S. that did not show any benefit to screening. Number two, there was a concurrent large trial in Europe that did show a benefit, but this is a number that you see cited a lot by members of the USPSTF, that really you save one life out of 1,000 in this sort of at-risk aged population. And so in their mind, that's not a really substantial number. So even though it showed benefit, that absolute benefit was relatively small. When you look at all-cause mortality, so death from any cause, not just from prostate cancer, it was similar in patients who got screened with PSA as those who did not. And the concern about prostate cancer screening is that in detecting a number of cancers that maybe would not have put people at risk for dying from prostate cancer, you're also putting men at risk of the harms of prostate biopsy, prostate cancer treatment, and so this notion of harms was very important. So what is overdiagnosis? And I've heard comments before from some of you in the audience about sort of overdiagnosis being a little bit of a concerning term because maybe in your opinion, any diagnosis is an important diagnosis, and so the term overdiagnosis may sort of undermine your experience as a prostate cancer patient. But from a technical sort of epidemiologic standpoint, we're talking about prostate cancer cases where that patient may never have died of their prostate cancer. So I just want to take the emotion out of it and just make it a technical term. And that might be up to half of the cases that are detected by PSA screening. And so when you look at the European trial, that means that you are diagnosing an additional 48 men for every cancer that might have caused death from prostate cancer. Now, we're going to critically evaluate that number, but that's what was highlighted by the USPSTF. There are a number of false positive tests. So there are a number of tests where you go through several screening rounds and you don't find prostate cancer in that patient. So PSA has a high false positive rate. Biopsy is not innocuous. So prostate biopsy, if your prostate were just this organ sticking off your shoulder, biopsy would not be a big deal. But there are life-threatening infections that can occur with prostate biopsy, so we can't just sort of disregard prostate biopsy as a simple procedure. And the notable treatment harms, and we're going to talk a little bit about this in the second session as well, include things like urinary incontinence, bowel dysfunction, which is more common after radiation, sexual dysfunction, things that truly impact men's quality of life. So when you look at what's happened in the prostate cancer landscape since the 1990s, there has been an irrefutable, so no one can really argue this, decline in deaths from prostate cancer since the 1990s, since around the time the PSA test was introduced into clinical practice. And that decline is about half. And so that's an important decline. But when you look at what the USPSTF attributes this to, they talk about all the sort of radical changes we've been able to make in treatment for prostate cancer since the 1990s. We now have robotic prostatectomy. Some people call certain types of radiation therapy robotic radiation, proton beam radiation, really cool therapies that we think maybe are more effective at treating prostate cancer. Well, we did a bit of a critical evaluation of this, and it's true that the treatment patterns for prostate cancer have changed. So this is before my time as a doc, but it used to be that prostatectomy, removal of the prostate, was sort of one of the rarer forms of treatment for prostate cancer. As PSA came about and techniques changed, surgery became more common. The type of radiation we use now is higher dose radiation than it used to be. We combine radiation with hormones because we know that's better and more effective than radiation alone. So we've learned a lot, it's true, in the last 20 years about how to more effectively treat prostate cancer. So if we use modeling, because this is not something where we can do a natural experiment, that would take forever. If we use modeling and we say, well gosh, if there were no changes to how we treated prostate cancer from the 80s, then this yellow line of prostate cancer mortality is what we would be looking at today. Mortality probably would have plateaued, it would not have continued to increase. If we look at the treatment changes that have been made since the 1990s and we model that impact on population mortality, it definitely causes a decrease. So if we model those treatment changes, we don't just say, well gosh, treatment's better. If we actually model those changes, yes, mortality would have improved. But there's a huge gap here. That improvement still does not account for what we actually saw in the United States. So what might account for that treatment? Well, if we include the benefit of screening that was seen in the European trial, now it's starting to look more like what we see in the U.S. So it's actually not accurate to say that this is just simply attributable to the changes that we've seen in treatment. Screening probably has an effect. And these next couple slides talk about the lifetime of a prostate cancer patient. So the 1 in 1,000 that was highlighted by the task force reflects the European trial that was 9 years of follow-up. So 9 years in a prostate cancer lifetime is relatively short. And so when you talk to members of the task force today, they still cite this 1 in 1,000, 48-to-1 ratio. But when we look at the same European trial after 11 years, so now we're looking at longer-term follow-up. Now we're seeing more patients in the unscreened population, those that did not get PSA, more of them are dying of their prostate cancer. Those numbers start to go down. And if we use our models, those same models led by Dr. Etzioni, and we say, well gosh, 11 years is not enough either. Let's go to a lifetime. Let's go to 20 years and beyond. Those numbers go way down even more. And now the number of prostate cancer patients that you diagnose with prostate cancer relative to the number that may die from their prostate cancer goes from 48-to-1 to 6-to-1. And that's a remarkable benefit, and that's something that not enough people are discussing. So this critical evaluation of what we're seeing as an impact of prostate cancer screening, and importantly as a cessation of screening, is really important. Now, one thing that was not discussed at all by the task force at all is the impact of metastatic prostate cancer. So when they looked at the screening test, they looked at the impact on overall survival, deaths from any cause, and deaths from prostate cancer. But one very important benefit of PSA screening is that in the 80s, when you took the entire population of men that were diagnosed with prostate cancer, about 1 in 4 were diagnosed with metastatic prostate cancer at presentation. So when they were first diagnosed with prostate cancer, they already had cancer in their lymph nodes, cancer in their bones, which can be very, very impactful from a quality of life standpoint, from a healthcare utilization standpoint. Avoiding metastatic prostate cancer is a tremendously good thing. Once PSA was introduced, the number of cases of metastatic disease dropped dramatically. And it became very consistent from the mid-1990s on that now about 5% of the newly diagnosed population had metastatic prostate cancer at presentation. So we went from 1 in 4 to 1 in 20. So we did a thought experiment where we said, well gosh, what if we just stopped screening? What if we stopped screening altogether, no one got PSA anymore? How long would it take to go back to these pre-PSA rates of having metastatic disease at presentation? And it would take about 13 years. So after about 13 years, if we just stopped screening with PSA in this country, we would see that same 1 in 4 rate of having metastatic disease at presentation, which is notably impactful and not really robustly discussed. So what can we do? I think one thing that really did happen with the USPSTF recommendation is that it caused us to take a more critical evaluation of our practices as prostate cancer clinicians. And so one thing we can do is we can screen smarter. And so what I mean by that is, I haven't really talked about the U.S. trial. And one big problem with the U.S. trial is it did not compare patients who got PSA with patients who didn't get PSA. It really compared patients who had an aggressive regimen of getting annual PSAs with patients that got more sort of occasional PSAs. And they both did really well. And so if you look at that trial, one thing that it may tell us is that, we don't really need to do aggressive PSA screening. We know from the European trial that there's a benefit to some PSA screening, but we don't necessarily need to do aggressive PSA screening. So Ruth and our team did some modeling to look at sort of how we can screen smarter to try to reduce the number of men that are diagnosed with prostate cancer that shouldn't have been or didn't need to be, but still maximize that population of patients whose life could potentially be saved from prostate cancer screening. And we went through 35, 40 different scenarios of prostate cancer screening. And what we learned is that you probably don't need to be screened on an annual basis. Every other year, even every 4 years, depending on what your PSA is probably adequate if you look at the population of prostate cancer patients. We also maybe need to think about the cutoffs that we use. And so there's this concept of age-related PSA. As we get older, our prostates get bigger, as I Am Joe said. And so as our prostate gets bigger, there is a more non-cancerous explanation for why your PSA may be climbing. And so if we use more age-related targets, that might allow us to capture the younger men at risk of potentially dying from prostate cancer and not over-capture older men who likely are not going to be impacted by a new prostate cancer diagnosis. Maybe we can also treat smarter. And Dr. Lin is going to talk about this in our session. But one thing that was highlighted by the task force was the fact that our treatments have notable quality of life impact. So again, if your prostate were just hanging off of your shoulder, it would be no big deal to remove someone's prostate. But your prostate is kind of the epicenter of the genitourinary tract. It sits below the bladder. So any treatment like radiation can impact your bladder function. It sits right above your sphincter muscle. So even if you have a perfect surgery, there is going to be at least some temporary impact on your continence. The sexual function nerves run right alongside the outer aspect of the prostate. So again, even if you have a perfect treatment with radiation or surgery, there is going to be some impact to your sexual function. And it sits right above your rectum. When we do prostate cancer surgery, we have to push your rectum down to get the prostate out. So if it didn't have this sort of critical location, it would not be as impactful a thing to treat, but the reality is that it is. So how can we treat smarter? Well, this was a recent publication using United Healthcare data, and it showed that still, as recently as 2006, we are very aggressive in treating prostate cancer. This was an update from some data from a registry called CAPTURE, and we'll talk about CAPTURE a bit in the second session. But it showed essentially the same thing, that the number of people in the gray boxes, in these lower gray boxes, that have conservative management strategies for clinically localized prostate cancer, it looks like it's decreasing, not increasing. Our brethren in the urologic community still are very aggressive about treating prostate cancer. And so what we need to do is we need to be more selective. We need to identify appropriate candidates for active surveillance, and that way we're going to diminish the harms of prostate cancer treatment. Now, I think, as we reflect on these recommendations, I think that the task force recommendation certainly understates the broad population benefit of PSA screening. It's hard to argue that PSA screening has not had an impact on prostate cancer mortality and the rate of metastatic disease at presentation. I think it does overstate the harms of screening. I think it overstates the harms of treatment. I think it looks at sort of a 90s approach to treatment, and even though our treatments are better, I also would argue that the harms of our treatments are less than they used to be. And really importantly, it ignores the impact of metastatic disease. Anyone who treats metastatic prostate cancer can tell you that metastatic prostate cancer, even if it's something whose lifespan is not going to be the cause of death in that individual, is a horribly impactful thing for that person to navigate. I do think, however, it puts pressure on us to be better clinicians, to be better doctors, to screen smarter, and to treat smarter, and Dr. Lin is going to talk a bit about that. But there are also some truths in screening that they seem to ignore. And the truth of screening, in general, prostate cancer, any chronic disease, is that really a small proportion of patients with a cancer are going to die of that cancer. A good screening test, an excellent test, is still only going to reduce a person's risk of dying from that cancer by a small amount. There is no perfect screening test that is going to eliminate, death from disease and also eliminate overtreatment. It's just not possible. With prostate cancer screening, it's true that we might diagnose 15 to 20% of the population and really only help 1%. But that's actually not a bad ratio. It sounds bad, but that's actually pretty consistent with a good screening test. And so the truth is that most of the cases that are diagnosed based on PSA screening may not be helped by it, but that does not mean that on a population level it's not an important test. I hope that makes sense. And so really when you look at it, screening by nature is imperfect, because when you screen, you hope to over-capture low-risk cases, because you're trying to catch everyone at risk of dying of their cancer. And so by necessity, you're also going to capture some men who aren't at risk of dying from their prostate cancer. But that doesn't mean it's a bad test. And so this is the work of the CISNET group, which is a modeling group that's coordinated here at the Hutch. But I also just wanted to take one quick slide to talk about some sort of higher level things that are happening with prostate cancer screening. So in 2012, when the USPSTF recommendation came out, Kathleen Sebelius, who was the Director of Health and Human Services, explicitly stated that Medicare will continue to cover PSA screening. And private payers, Blue Cross Blue Shield, a lot of the private payers that you think